and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. In today's episode, we discuss best practices when managing patients who are immunocompromised with COVID-19 in the hospital setting, from understanding the burden of COVID-19 in this population to providing guideline concordant care to optimize outcomes. I'm joined by three expert faculty: Dr. Cristina Mussini from the University of Modena in Italy, Dr. Martin Witzenrath from the University of Berlin in Germany, and Dr. Michele Bartoletti from the IRCCS Humanitas Research Hospital in Italy. This episode is part of a larger educational program titled COVID Rounds, Clinical Case Discussions on Best Practices for Inpatient COVID-19 Management. For more information on our faculty, along with the link to the larger educational program, please visit the link in the show notes for this episode. Now let's get started with Dr. Mussini.
So let's start talking about the COVID burden in immune compromise, because this is the topic of this roundtable. There is an important cohort. The immune compromised individual was 3.9% of the study population. So the outcome was in 500,000, and these 500 were 3.9% of the study population. But if we look at the percentage is low. But if we look at the rate of hospitalization, we see that this population accounted for almost 22% of hospitalization, almost 25% of those who had more than 3 vaccinations, but especially 24% of death. And among the deaths, 25% of the deaths were fully vaccinated with more than 3 doses. So looking at the risk of hospitalization or death among the immune compromised, all immune compromised have an increased risk compared to those who are non-immune compromised. But we have to underline that especially those who underwent stem cell transplant within 2 years, or those with solid organ transplant, and especially on anti-rejection drugs, they really had a much higher risk, not only of hospitalization, but especially of death. Why this? If 1/4 of those who were hospitalized and 1/4 of those who died were fully vaccinated? Because among people who are immune compromised, and especially among those who have hematological disorder, we know that there are multiple factors that may affect vaccine efficacy. In this slide, we see those who have chronic lymphocyte leukemia or other lymphoid malignancies that were studied and published in this paper. You see that there are vaccine factors, dose intensity and frequency. We are talking about 3 doses, but actually, probably since we know that the response to vaccination fade with the time, we know that it's important that these people continue to vaccinate themselves. So 3 maybe are not enough. There are also patient factors like age, comorbidities, hypogammaglobulinemia, but also treatment factors. For example, not seeking for treatment as soon as possible. So doing something like watch and wait, or having been previously treated, or having active treatment that can reduce either hospitalization or mortality. Of this reduced number of people mounting an immune response, there is still a question of antibody titers. And this because it's not only about the quantity of antibodies, but especially about the quality of the antibodies, in order to understand if they are a neutralizing antibodies, really protective one or not, and the persistence of the defense. So that's why we can have, when all these factors work in the right direction, a reduction in the clinical incidence of the infection. But if some of these situations don't go in the right direction, we have an increased risk of hospitalization and of death.
So let's go to our patient. The patient that we do see here is a 45-year-old woman with a recent diagnosis of mediastinal lymphoma that is admitted for febrile neutropenia, mucositis, and acute respiratory failure. She reported URI symptoms with coughing and sore throat that began 2 days ago. The vitals are a temperature of 38 degrees Celsius. Blood pressure is 130/85. heart rate is 90 beats per minute. The respiratory rate is 24 breaths per minute, and the saturation is 89% resting on room air. Her home medications were epoch rituximab that she received with the last cycle 2 weeks ago, acyclovir, fluconazole, and levofloxacin, and trimethoprim sulfamethoxazole. Her vaccination status was a completed initial mRNA series that was boosted in 2021, and she had COVID-19 in 2022, so 2 years ago. And now her COVID-19 antigen test is positive, and she has been initiated on IV vancomycin, cefepime, and micafungin for febrile neutropenia, and acyclovir is continued. So the question here is now, should any COVID-19 therapies be initiated? First of all, of course, we need a complete diagnostic workup for the COVID-19 disease, and this includes the standard H&P, the assessed severity of the disease and risk factors for progression to severe COVID-19, and I'll go into details of this in a minute. Lab testing has to be completed. We need a PCR for SARS-CoV-2 and a CBC with a differential and a CMP, and maybe other labs as appropriate regarding her comorbidities. With respect to imaging, chest X-ray needs to be done, and I personally strongly suggest to do a low-dose chest CT scan in these patients. We need an ECG or EKG, and again, depending on the comorbidities of this patient, other studies. Now, how do we assess clinical severity and the probability for worsening? Of course, it's important to look at the QSOFA criteria that we always use in patients with infectious diseases presenting to the hospital. So is there a new onset of confusion? Does the patient have respiratory rate equaling 22 breaths per minute or more? Is the systolic blood pressure below 100 millimeter mercury, or the oxygen saturation below 92%? And this is particularly important in COVID-19 patients because they very frequently experience what we call happy hypoxia, which means that they have low oxygen saturation, but they do not suffer from it, so they do not increase their respiratory rate. And therefore, it's important to quantify oxygen saturation in these patients and not only measure the obviously very important respiratory rate. We also look for PCO2 if we have a blood gas analysis, because patients who are breathing more have lower PCO2 values. And we look for a serum lactate because increased serum lactate is a bad predictor for unfavorable trajectories. And we also check for acute renal failure for specific comorbidities like pulmonary or cardiovascular or other comorbidities, and of course, for severe immune suppression. Regarding these diagnostic considerations, I would like to ask my two colleagues how to determine if the patient is getting worse and then what to do. What do you usually do, Michele?
This is a great question. I think what you already show is very important. I think that first of all, clinical evaluation is much important for these patients. So we have to check everything that can be foreseeable for a worsening condition for this patient. Obviously, past medical history is very important because we know that some immunocompromised patients has a higher risk for developing severe condition or progress to critical condition as well. And then in terms of labs, I think that inflammatory markers could be a good option. So we know that there's a lot of literature talking about CRP, about procalcitonin as well, even though we know that we use this for differentiate between patients with the bacterial co-infection or supra-infection. We can use interleukin for assessing the severity of patient, but I think that the best way, again, is to assess normal SOFA score, QSOFA sometimes.
Cristina, would you like to add anything?
Yeah, obviously the clinical examination is the most important, but if the clinical examination is not so clear that the patient will progress, we look at the CRP. Say sometimes you have a sort of, a contradiction between the clinical picture and CRP that is increasing. These are people who can have a bad prognosis. So, and also when you have to decide when to use, for example, we will talk about treatment, but also immune modulator. I think that CRP is very easy, it's cheap, and it's something that is in our routine. While, for example, IL-6, is not, we don't have a real cutoff. For CRP, we have some values from the trials that were conducted during the first waves. Probably they are not the same in immune compromise in the Omicron era, but still, as all the markers, I think that the trend is the most important. If you see an increase, it's something that I would have a look on.
Now, the two of you are great experts in IT. Is there any use in consulting other disciplines, maybe critical care or any other?
Absolutely, yes. I think that the decision of any treatment and program for the patient should be shared with all members and all, I would say, main character of the patients. What does it mean? We are talking about immunocompromised patients. So I think that the decision on the type of treatment and the pathway that the patient should follow should be shared with, for example, hematologist or solid organ transplant unit specialist, intensive care unit specialist, because I think altogether anyone can give very important information and very important skills for the good of the patient. So I think the multidisciplinary approach is very, very important in this case.
And before we step into treatment of COVID-19, it might be useful to briefly recall the normal trajectory of the COVID-19 disease upon SARS-CoV-2 infection. Of course, you all know that after the infection, people are infectious even before symptoms start. And at that time, they are asymptomatic, but then symptoms may start with mild symptoms. And then in the worst cases, these patients may experience a trajectory to moderate and even severe disease states where the SARS-CoV-2 RNA is usually going down to low levels in the moderate and severe disease states. However, particularly in immunocompetent patients, the SARS-CoV-2 RNA levels may stay relatively high, and we will have to discuss this with respect to treatment options. Now, the normal or usual care of patients with symptoms is in outpatients that you can consider to give antivirals, and in those with moderate or severe disease, so in inpatients, antiviral therapy may be your choice alongside with potentially with immunomodulators, depending on the patient, on the severity of the disease, and on the question whether the patient is immunocompetent or immunocompetent. And if we look into the NIH COVID-19 guideline recommendations, you will see that in the ambulatory setting, in patients who are treated as outpatients or are hospitalized for non-COVID-19 reasons, but have a positive COVID-19 or SARS-CoV-2 PCR, steroids are not recommended, and antivirals are recommended in patients that are at high risk of progression, and then only within 5 to 7 days of symptom onset. For example, nirmatrelvir, ritonavir, or remdesivir. And molnupiravir could be an alternative. In hospitalized patients without oxygen, again, steroids are not recommended. And again, at high risk of progression, remdesivir is recommended in hospitalized patients that need oxygen or are on high flow oxygen or non-invasive mechanical ventilation. Dexamethasone and remdesivir are recommended in the NIH guidelines. And in hospitalized patients in the ICU on mechanical ventilation or on extracorporeal membrane oxygenation, the remdesivir treatment can be considered in patients who are immunocompromised and have evidence of ongoing viral replication or less than 10 days since symptom onset.
Thank you to our faculty, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, COVID-19 rounds, clinical case discussions on best practices for inpatient COVID-19 management, please click on the link in the show notes. And to get access to all of our new podcasts, subscribe to the CCO Infectious Disease Podcast on Apple Podcasts, Google Podcasts, or Spotify. Thank you and have a great day.